have head and neck cancer patients, they are the tumor site with the highest suicide rate and depression and anxiety, 3 times more than any other tumor site. Something that I've actually been pushing a lot lately is the real bulk of this is in survivorship. Their psychosocial and their psychological issues as a whole, they start to really pan out after treatment. Mental health, the stigma is there no matter what, whether you have cancer or not, if nobody wants to talk about it.
So hello everyone, nice to meet you again to a new edition of Beyond the Cancer Diagnosis interview series. Today it's my pleasure to have Alessandra Alvarez. She's a nurse navigator at Miami Cancer Institute. Alessandra, nice to see you. Thank you for accepting our invitation. And together we'll speak broadly, because the topic is very, very large, about patients with head and neck cancer. But to start our interview, I would like to ask you to introduce yourself and to elaborate on what nurse navigator means, especially for head and neck cancer patients. We know what a patient navigator means, but we are not sure what a nurse navigator really does.
Okay, so first and foremost, thank you so much, Adrian, for inviting me, like you said, to talk about a topic that I could go on forever about. So I do appreciate it. And so getting to it, again, I'm Alessandra. I am a nurse navigator for the Miami Cancer Institute at Baptist Health. I started off actually as a patient navigator. So that is the non-clinical component of a navigation system. And now I am a nurse navigator. So I basically, I am the clinical component, but I still do a lot of the things that a patient navigator would do, because at the end of the day, we are advocates. And, especially when I meet patients, I tell them, I am like your ally. I am the middleman between you and the entire healthcare system. And I'm going to guide you from now up until the end of whatever it is that, they decide that they're going to do, what the recommendations are. And so it's nice because, you are an extra layer of support. And especially on a first visit, these patients, they get an overload of information. I mean, the diagnosis alone, any diagnosis is shocking. And sometimes patients, they don't understand. They don't really capture the essence of what is happening. And so that is where I come into place. And I kind of get to know them, not just focusing on the diagnosis, but the patient as a whole. So I want to know, are you working? Are you a parent? Do you have children? Do you have support? How much do you actually understand about what's going on? And so the clinical part of the nurse navigator would be, for example, when they're discussing the treatment plan and what's to come. We kind of reiterate and we reinforce what the doctor or the nurse practitioner has already mentioned. Because again, first day is an overload. And even though you can still follow up with the team, they might be busy or they're seeing patients. And so the patients can always reach out to their nurse navigator and say, hey, what should I expect? I know they explained everything to me, but if I feel, X, Y, and Z symptoms, who do I call? Is that normal? So it's a lot of reinforcement for the clinical part in expected symptoms, what comes next. If they want to be, paired up with social work so they can maybe get in tune with a support group to discuss with other survivors what they went through. So it's a lot of different things. Basically, a nurse navigator is constantly referring and finding resources for the patients. And I actually work with a patient navigator because, if I'm with a patient and they tell me that they have transportation barriers or lodging barriers, then my coordinator or patient navigator, it's the same thing. They can already start working on that, finding out, what's around the area. And so that's extra help for me, but it's actually help for the patient as well, so we can work more effectively and in a timely manner.
We all know that the most important person in all this process of cancer care is the nurse, because also for us as psych-oncologists and for sure for doctors, the aid or the help from the nurse part is essential, because you are the closer person to the patient. So except all the, let's say, clinical terms that you talk with him, you also find out many sensitive subjects or information that in the future, in the cancer treatment trajectory, will help us a lot in doing what is correct for each of them. I saw another terminology of patient coordinator. It is something different, or it's in connection with what you have mentioned before?
It's another term. So in navigation, when you have, because not every institute has a navigation team. And if they do, not all of them have both the patient navigator and the nurse navigator. So a patient coordinator is the same exact thing as a patient navigator, just a different name. So in some places you'll see maybe they'll call them like a care coordinator. It just depends, but it's the same exact thing. One is non-clinical and is more administrative support, and then the nurse, is the clinical part, and you work together to help the patient ultimately.
I will want to ask you now, from all the different cancer types, why head and neck cancer? Because you have like a long history, experience in this field. It was something, let's say, from the family, or was just a choice at the beginning of your career?
I like to, I feel like a lot of nurses that work in oncology say the same thing. Like, it's a calling. It's not something that you pick. So as far as head and neck, choosing that tumor site, I was fortunate enough when I started as a patient navigator, I was the one to follow the most sites. So the nurse navigator that I was working with at the time, she, we were following together GI, we were following skin cancers, head and neck, endocrine, unspecified. So, cancers that didn't have a primary. And I saw the complexity that head and neck cancer patients, the volume was not high, but the acuity of care was nothing like I've seen with the other tumor sites. And it's not to dismiss, that any other tumor site, has less barriers or psychosocial needs, but this is a tumor site that, again, one person alone, it's not enough. They need a huge team. And so I knew immediately, like, once I was going to finish nursing school, if I was going to be a nurse navigator, I only wanted to work with head and neck cancer patients. And, it's been already 3 years that I've been working with them as a nurse, but ultimately I've been working with this population the most since I've been in navigation, which is going to be 8 years now.
So it's quite an amount of time. And you mentioned also the other different types of cancer. What are the main challenges faced by head and neck cancer patients? I know, for example, other categories of patients, but in this specific one, which are the most challenging facts for them?
There are so many, because this is the only cancer that affects, your face. Like, it's the place that you can't hide, not just your face, your mouth. This is where you talk from. This is, where you can breathe through your mouth, you swallow, you eat, you do so many things with your mouth. And, nobody really realizes how much we need it and how much we do until something, goes wrong. And the thing is that these patients, unfortunately, their treatment is pretty rigorous, no matter what way you look at it. It's not one of those that the majority require more than one modality, and it's a long treatment. So you were talking about different kind of surgeries. When you tell a patient, hey, we need to completely remove your vocal cords, they're never going to talk again. Sure, they can get, a valve or a passing or something, but it's not the same. And so these are big time life changing scenarios that any other tumor site is not going to go through, because you can't hide. You can't hide like facial disfigurement from a life-saving surgery that they had to do, like a mandibulectomy, the larynx. It's very complex. And so even though especially the HPV positive patients that have such a high survival and great prognosis, the quality of life never really goes back to what it was. And it could be like that you don't taste food the same ever again. And so again, like when I started seeing with time how intense, this treatment was, I'm like, there is no way, because this can't just affect the physical. I mean, it is affecting the physical, but it's going to affect your emotional. Like if you're not able to swallow correctly, that means that you're more than likely not sleeping. If you're not sleeping, you're going to start having anxiety, and then it's just like a buildup, right? And again, a lot of these symptoms are very common. And so it's just when you see the toll that it takes on you, you just want to make sure that you can offer as much support and resources to these patients as possible. Even, caretakers, like they don't know how to even approach this. Like I said, I feel like the total laryngectomy ones are the most intense, especially when they're young and they have kids. And, I can go on and on about this, but they have head and neck cancer patients. They have they are the tumor site with the highest suicide rate and depression and anxiety, 3 times more than any other tumor site. So that tells you enough to know that this is a treatment and a cancer that unfortunately they don't find it until it's already a little bit more advanced than it should be, because people don't go to the dentist. Nobody thinks that, hey, cancer, you usually think cancer and you're like, okay, maybe breast cancer or colon cancer, like the very common ones. But then you would never think something that in your mouth, like a dot, that it could turn out to be something like head and neck cancer and what that entails. So it's very scary. It's the unknown, and it's not just the treatment, but it's the quality of life after. So
I would like to make here a nuance. You talk about facial like expression at the end, and we are always talking about the issue of body image, but here is the nuance of self-image, how I see myself as a result of this type of cancer. And I guess this is maybe the most challenging issues out of all of them. When you look yourself in the mirror and then thinking and see the new reality, I guess, and I tried to understand how difficult could be and how shock could have each of us at the end, to see yourself image disturbed by, as you mentioned, something that the day before you didn't thought that could be. And the idea of suicide risk and these statistics scare me a little bit, because suicide nowadays, it was mainly associated with or correlate with cancer, but nowadays there are many other fields when we are talking as a clinicians about suicide. And how can or you or the specialist try to not to reduce, but at least to maintain this rate, not to go higher of suicide? There are specific interventions.
I mean, honestly, I think more than anything, especially me as a nurse navigator, which again, I'm supposed to be like your best friend, the patient's best friend, we need to ask the right questions. mental health, the stigma is there no matter what, whether you have cancer or not, if nobody wants to talk about it. And so if I'm not asking the right questions, the questions that are pretty uncomfortable, then we're not going to know. And I think that, again, as a nurse navigator, that I work with every single modality, everybody that's in the patient's team, down to the nutritionist, the speech language pathologist, cancer rehab supportive services, the psychiatrist. I mean, it's a huge team. And as long as we are all on board, which I am so grateful to have the best team that is so supportive now, especially with mental health, because they've seen with time, like this is bad. And it's gonna get worse with so many things going on around the world, and economy and financials and whatnot. We need to be making sure that we are checking up on these patients consistently. And so before I even meet the patient, I'm already checking their chart, seeing kind of like what to anticipate. What am I getting into? Because I want to make sure that I don't miss asking the right questions. Because even if the patient is not receptive at the beginning, they usually are later on. And so that's when I talk to the social worker so she can do her mental health assessment. From there, she'll talk to the psychologist or the psychiatrist. And then even when we want to go ahead and involve the patients with our psychiatrists or whatnot, some of them are reluctant. Again, the stigma, they're like, I don't need to see a psychiatrist. I'm not crazy. There's nothing wrong with me. And so that's where our palliative team comes into place, which I absolutely cannot be like, I mean, they are amazing. There's patients, again, that either A, they're reluctant to want to see somebody in psych, or B, where their insurance is not accepted. So then what happens next? Our palliative team, again, that's another stigma where you hear palliative care and they're like, no, it's hospice. Like, what are you doing? Like, I don't need their help. And so for myself, again, I'm introducing all the resources that we have, and I try to be as detailed and as realistic as possible. Like, hey, our palliative team, they're not hospice only. They are here to help with any pain management, but they also see the patient as a whole. They're looking at you from, a bird's eye view. So even if you don't end up seeing them later, please make the appointment. We're going to set you up, because maybe right now you don't have pain or any worries, but you might have later down the line, and we don't want to have to wait, not even days. Like, I don't want to say we don't want to wait like over a week to get you seen, because our palliative team, a lot of their consults, it's a lot of psych. I want to say 80% of their consults are psych. So they can also help and kind of mitigate the situation and make the patient feel comfortable in the sense that, like, hey, we're also here to help you. And with time, they eventually go see the psychiatrist or the psychologist. But in the meantime, our palliative team, they can go ahead and, prescribe something that can help you sleep better, or prescribe something, minimal that can help you with anxiety. I have a lot of patients that even for the CT simulation, which is the mask making, they get anxious because you're laying on this like flat hard surface. You have this sheath over you where they're trying to fit the mask and everything, and you're there for over an hour with tons of people around you. And sometimes they don't know that it's going to be about an hour, sometimes even longer. So I kind of like, again, just to take away the unknown, because I feel like the unknown is a lot of where the anxiety comes from. And so I tell the patients, I reiterate about what to expect, what's to come, who you're going to see, who you should see, even if you will never see them again, but just have them in your back pocket. And I think that multidisciplinary approach is the most effective to make sure that we don't lose these patients because they fall into a depression, because they get anxious, because they have no support. And so, if I worked with a team that was just like, I don't want to deal with that or whatever, then we would probably have a lot of delays. It would be a lot harder for the patient to actually embrace the mental health part of this entire process. So definitely a strong multidisciplinary approach is the way to go.
You said that you had to ask the correct questions, but you also have to answer to a question, to why me question. This is the question of each cancer patient. Why me? And as we all know, there is no standard answer. So how would you answer to these questions? Why me? Because that's the first one. Before you ask the correct questions, you have to answer to why me.
And I'll never forget that exact question. I was still a patient navigator, so I was not that familiar with the clinical part. And I remember that I was helping out my nurse navigator that day, and the first time that I got asked that from a patient, I froze. I was like, like, what do I say? And I was just like, I'm not sure. We all like, we never know why things happen to us. But what I can tell you is that we're going to do whatever it takes to make sure that we get you through this. Granted, the first time they asked me that, like I said, I froze and I was just like, I am so sorry. I don't have a response. Immediately, I called a social worker and I was like, oh my God, I feel horrible. Like, what do I do? How do I even approach this? Because I know that it's going to happen a lot more and I'm not going to have anybody around me. And I don't want to leave the patient hanging. That's the last thing that you want to do. You want to make sure that they feel heard, that they feel safe. And she guided me and she's like, there's so many ways, like there's never going to be a right answer because at the end of the day, we don't know. We don't know why cancer chooses us or the severity and stuff. And it makes us question a lot of things. Like there's patients that will say, why me? I never smoked. I never drank. I've eaten healthy. I exercise. Like, why? And when we don't have a response, because at least for head and neck cancers, we always say there's 3 factors: drinking, smoking, or HPV positive. And about 80% of these cancers are HPV positive. So it's, when they ask why me, we can tell them about, HPV and how that happens and it's a virus and whatnot. But when it's none of those and, again, I listen to them and I tell them, I am not sure exactly why.
I wish I knew what to say.
Yeah. And I'm like, but we're going to do whatever it takes. And you're not alone. We're going to do this together every step of the way. And we're going to figure out how to make sure that we can, if I know it's going to be curative intent, we're going to do whatever it takes to get rid of it. Or B, if I know that it's going to be more for palliative intent, I tell them we're going to do whatever it takes to make sure you have the best quality of life. And then we focus on your goals of what's to come. But why you? I wish I had an answer for that.
And the most important thing in all of this why me question is just to be honest, to be sincere, because the patients feel if you are honest, even though we don't have an answer to these questions, but they feel our empathy and honesty. We've talked till now about challenges in head and neck cancer, and you mentioned the anxiety, depressions, and other factors that might influence patients not to return or complete the treatment. Are there, let's say, any opportunities or any, let's say, light at the end of the tunnel that we can work on? Because when we are talking about challenges, usually we are talking about opportunities also. In each field, in each situation, if it is a challenge, should be an opportunity. And the opportunity usually comes from within the patients, within his or her grief, suffering, and at the end, destiny. How do you feel people react to this, let's say, post-traumatic?
Like the survivorship, the after part. Right. I mean, you said it, post-traumatic. It absolutely is very PTSD worthy. I mean, like I said, this is a rigorous treatment. It involves usually chemo, radiation for 7 weeks. And a lot of patients have surgery prior to that. So yes, absolutely PTSD. And I think that again, working with a multidisciplinary approach and following these patients after, because people think like, oh, last day of treatment, like that's it, it's over, cancer's over, and I can go back to normal. But something that I've actually been pushing a lot lately is the real bulk of this is in survivorship. Their psychosocial and their psychological issues as a whole, they start to really pan out after treatment. And so I think a survivorship clinic is extremely important. And every cancer center is different. It depends how many people you have staffed and whatnot. But I try to at least, I tell the patients what to expect for the most part, right? So they're not like shocked and, oh my God, like nobody told me. And I always tell them, look, the last 2 weeks of your treatment and the first 2 weeks post-treatment, you're going to feel your worst. I don't know how bad because everybody is different, but it's usually like the most critical part, right? And then afterwards, within months and weeks, like everything starts to get better. But then again, there's challenges like patients wanting to go back to work, but then they have a tracheostomy. And so it's that anxiety, like, I'm going to go back to work. Everybody's going to be looking at me, so when you work with a very comprehensive team that is on top of these patients, it helps. And it helps a lot when you already know these patients and hey, look, this patient lives all the way in the Keys. He already had transportation barriers. So the risk of him not coming back is pretty high. I mean, he's going to finish his treatment because we were able to get him lodging during the duration of his treatment. But what about after? How are we going to make sure that he comes back? I mean, he just went through a treatment it's rough. He didn't have transportation. He couldn't work. And then now we basically like released him back and he's not going to know what to do. And he might not want to deal with it again. He's going to be scared. There's a lot of people that are scared to even have that 3 months post PET scan because they don't want to know, they don't want to go through this again. And so it's important that we all work closely together and like the radiation oncologist, the medical oncologist, and follow these patients closely, at least, which we do at least the first 2 years. And from the very beginning, I ask patients, do you have a primary care doctor? Because if they're not going to come back to us, at least follow up with your primary care doctor because somehow we will end up talking to them and we'll get the patient back. And it's all working within a multidisciplinary approach. That's the only way to make sure that we keep these patients coming back and that we're following them at the best of our ability because it's so many different moving parts. Even the dental, I mean, that's like a whole other, I could spend 30 minutes, 1 hour just talking about the dental part. I mean, it's the one thing that even can create a barrier of the patient not wanting to come, not having enough money to even get the things that they need before starting treatment. And then again, they don't want to go back after. So it's just really a lot of education, reinforcement, re-educating these patients and hope for the best. From the very beginning, though, not at the end. I tell everybody, don't wait till the end. From the very beginning, we need to start having these discussions. We need to start asking those questions. We need to make sure that we're all communicating weekly. And we do. We really do. So,
since we are at the end of our interview, the time just passed quickly. I would like to ask you one more question, if you cannot answer me shortly. After all this experience, years, cases, patients, how you see hope? How you define hope with your own words from your experience?
Hope, you can easily lose hope with a cancer diagnosis. And I tell everybody, if you don't believe in anything, then you stand for nothing. And you got to have a reason to push. And hope is that reason. No matter what the treatment outcome is, whether, again, it's curative or palliative, you need to have something to fight for. And so that's hope. That's, knowing that there's going to be something better on the other side. And I don't mean the other side like, if they're passing or what. I mean the other side like after post-treatment, post-cancer, a new life. And so that is what hope means to me. It's fighting for like that new version of yourself.
Alessandra, thank you very much for being
Thank
with
you.
us today. Good luck, because you need it in this field, as you talk with a lot of challenges, and it is very important to know that patients should come back and should never lose hope. Thank you very much, and good luck for that.
Thank you.
Don't forget to like, comment, share, and subscribe to OncoDaily on YouTube. Hit the bell icon to stay updated.